ER and trauma. So what is trauma? So what is trauma? The general public tends to use the term trauma to any type of crisis ranging from a heart attack to psychological stress. Among healthcare professionals, though, trauma refers to bodily injury. Trauma centers have their roots in military medicine. Today's trauma center in the United States is a specialty care facility that provides competent and timely trauma services to patients, depending on its designated level of capability. Level 1. To provide full continuum of care for all patients. A Level 1 is a regional resource facility that is capable of providing leadership and total care for every aspect of injury, from prevention through rehabilitation. They have a responsibility to provide and offer professional and community educational programs, conduct research, and participate in system planning. They have strict accreditation standards. Level 2 are community hospitals. They provide care for most injuries and they send major injuries out. Level 2 provides a significant leadership role in injury management, education, prevention, and emergency preparedness planning if there is not a Level 1 hospital in the community. Level 3 are community hospitals. They stabilize major injuries and then send them to a bigger facility. And Level 4 are in the rural and remote areas, and they provide advanced life support and then they transport out to bigger facilities. Mechanism of injury. The mechanism of injury describes how the patient's traumatic event occurred, such as a high-speed motor vehicle crash, a fall from a standing height, or a gunshot wound to the torso. Two of the most common injury-producing mechanisms are blunt trauma and penetrating trauma. Blunt trauma results from impact forces such as motor vehicle accidents, assaults, falls, blast effect. There is a rapid acceleration and deceleration forces that causes injuries by tearing, shearing, or compressing anatomic structures. It results in trauma to bones, blood vessels, and soft tissues. Penetrating trauma are results from sharp objects and projectiles such as knives, stab wounds, gunshot wounds, fragments of glass, metal, and shrapnel, and they are usually life-threatening injuries. Stat intervention. A basic tenet of emergency care in any environment is scene safety. In the pre-hospital setting, emergency care provides must ensure that they are aware of any hazards that might pose a threat to rescuers and take actions to decrease or eliminate the risk. The same concept is used in the hospital. Before engaging in trauma resuscitation, remember there is a high risk of contamination with blood and body fluids. You want to use standard precautions in all resuscitation situations. The initial patient assessment in trauma is the primary survey. It's an organized system to rapidly identify and effectively manage immediate threats to life. You want to think about the ABCDEs. A. Airway, B. Breathing, C. Circulation, D. Disability, and E. Exposure. A equals airway. It's the first priority. You want to establish a patent airway. Clear airway of any secretions. Maintain the C-collar unit until cleared by X-ray and physician. Administer oxygen if necessary. May need a nasal cannula or a non-rebreather mask or endotracheal tube. B equals breathing. This is the second priority. Is the patient spontaneously breathing? Are ventilatory efforts effective? Assess the breath sounds, the pulse ox, chest expansion, respiratory effort, chest wall trauma. Are there any physical injuries? Patient may need a chest tube, a needle thoracotomy if they have a pneumothorax. Do they need CPR? C equals circulation. Assess the heart rate, blood pressure, perfusion, capillary refill. Threats to circulation include cardiac arrest, heart attacks, hemorrhage leading to shock. The goal is to restore effective circulation through CPR, hemorrhage control, IV access for fluids, blood, and medications. External hemorrhage is controlled by direct pressure with clean, dry dressing material. Monitor the blood pressure. Presence of a radial pulse, blood pressure of at least 80 systolic. Presence of a femoral pulse, blood pressure of at least 70 systolic. Presence of a carotid pulse, blood pressure of at least 60 systolic. If hypotension occurs, shock has already set in. Body has already used up the compensation mechanism. Place a large IV, at least a 16 to 18 gauge, in the AC space. They may need a central line in the femoral, the subclavian, or jugular. They may also end up with an intraosseous line. Typical IV fluids are lactated ringers or normal saline. You may have to hang blood, plasma, or platelets, and they may also need warmed IV fluids. D stands for disability. You want to check the Neuros. An acronym is AVPU. A for alert, V for responsive to voice, P responsive to pain, and U unresponsive. We also use the Glasgow Coma Scale, which measures eye opening, verbal response, and motor response. A normal score is 15. The lowest score is 3. E equals exposure. You want to cut away clothing for a complete assessment of a patient. Clothing may be evidence, so follow institution policy and handle it appropriately. Cover patient with warm blankets to prevent hypothermia. Hypothermia causes can be vasoconstriction, difficult venous access, arterial access, coagulopathy, increased bleeding, may have a slow drug metabolism. Interventions are going to be to remove wet sheets or clothing. You want to cover with warm blankets, infuse warmed IV fluids, and increase the room temperature, and use a heat lamp. After the immediate life threats are addressed, then the patient may go for CT scan, X-ray, ultrasound, surgery, and the nurse goes back through the patient and conducts a more thorough assessment and does lower level interventions such as placing an NG tube or inserting a Foley catheter. This concludes part 2 of this lesson. If you have any questions related to lesson content, contact the instructor.